PhD, my first reaction when I think about ramucirumab and NIDD came and told me was that we are actually looking at the history channel, you know. I mean, you're not looking at something which is very basic, you're looking at something which is very old, and it's not my problem. This trial came in 2014. My subsequent reactions on this was that people who don't learn from history are the one. We should learn from the history, and we should learn it and embrace it, because those who don't learn from the history are doomed to repeat it. So let's just start with, first of all, you should change your slides, so you should change the way this thing runs. So let's get real about immunotherapy in non-small cell lung cancer. This is the data from Vanitha Naruna group, and I'm sure that she knew that I was going to come and quote her data, that is why she's not there. You look at it, only 1.61% from Tata could receive immunotherapy in the second line, and that's the reality. This is the data from us where we all combined our data. Only 74 patients received immunotherapy. This happened 2 years back. Out of all the things that we say, nivolumab, pembrolizumab, atezolizumab, only 1 to 2% or 5% of people are able to take immunotherapy. So the remaining 95% of people don't get immunotherapy, and there is where we actually coming from. This is our data basically from immunotherapy. Again, if you see, 68 patients from 2016 to 2021 were taken up for second line non-small cell lung cancer treatment. So there is definitely a science over there. So let's say we have a 45-year-old female, stage 4 non-small cell lung cancer, NGS no actionable mutation, PD-L1 negative. Given 3 cycles of PEMCA, PET scan shows a partial response to treatment. After 6 cycles, it's a progressive disease. The options of treatment we have are immunotherapy, docetaxel, lorlatinib, docetaxel, and anti-angiogenic agents are best supported here. Let's go back in time. How did docetaxel actually come into play? Are there any resonance over here? Okay, fantastic. Unfortunately, you are the target next. You know, docetaxel is the king, I said. But if you look at it over here, the response rate with docetaxel is 6.7%. The overall survival is basically 5.7 to 7.5 months. And a 1 year survival is basically only 32 to 37%. And there is where the lung cancer was all about. You know, I mean, when we were doing our DM, there was no YAR of lung cancer. There was only YAR of breast cancer. There was no lung cancer conference. People who used to get lung cancer, people who used to treat lung cancer were never looked upon as celebrities. So actually a punishment posting, that is what we actually say. Docetaxel came in 2001. Then docetaxel was compared to pemetrexed, you know. Pemetrexed was not better to docetaxel. Pemetrexed was equal to docetaxel with a good quality of life actually on that. If we have to identify this star, I thought people will be sleeping in this. This is actually Salman Khan, which I am not going to tell you. Then, so basically, docetaxel has been there. We have seen docetaxel with sotorasib, we have seen docetaxel with other agents which have not really been able to see. So, this trial, Revel trial, compared dosi versus dosi plus ramucirumab. Again, both squamous and non-squamous were taken. This basically compared, and people could have taken paclitaxel chemotherapy before. Primary endpoint was overall survival, not the PFS with sotorasib trial showed. So I'm just trying to tell you the differences in the trial. Prior Bev was allowed, untreated CNS Mets basically were allowed. Major blood invasion or encasement by cancer or significant intratumor cavitation was the exclusion criteria. So that's important. Squamous was allowed, prior Bev was allowed, prior taxanes were allowed. This was the basic patient demographic and characteristics, which is by and large equal between the two. And what it basically showed was, I mean, although LIDD won't show, but a significant improvement in PFS of OS, PFS and HR, but there was an OS advantage of 1.4 months. Now, please remember the trial which Randeep presented in sotorasib, there was a detriment of 0.8 months in sotorasib versus docetaxel. But this is the only trial which has shown an advantage over docetaxel of 1.4 months. The PFS was better, 4.5 versus 3 months, 1.5 month advantage. The overall response rate was better. People who had got prior treatment with taxanes, that is you have paclitaxel to start with, you can still get docetaxel and people will be better with that actually. The primary endpoint was OS, 10.5 versus 9.1, and this is exactly the graphs that we used to be. We grew up seeing these graphs, you know, in lung cancer nothing used to work. This was ITT. If you actually convert them between a squamous and a non-squamous, again non-squamous did also better, squamous also did better. in fact, the magnitude of benefit was slightly better with the squamous one rather than non-squamous one. The secondary endpoint was the PFS, and again there was a slight 1.5 months advantage. And just remember, it's the same 1.5 months advantage in which CRSF has gone and applied for an FDA approval, and everybody is going gaga and gung-ho about it 1.5 months PFS. Again, this response rates were there in both the histological types, squamous also and non-squamous also. The response rates were much more higher in the squamous population. Now, the major problem which think about when we have a 1.1 month advantage is whether there is a treatment related adverse effects, whether the adverse effects are higher or lesser. And when you use an anti-angiogenic agent, you are very much concerned basically about the hemoptysis and the bleeding manifestation. That is something which is very, very important. That is something which I want to show. The incidence of GI hemorrhage, epistaxis, hemoptysis, pulmonary hemorrhage was absolutely equal or slightly higher in dosi plus ramucirumab, plus it didn't really go and shot out through the roof. I mean, it was absolutely okay. So there was not much, hemorrhagic event. That is something which we are very scared about when we give ramucirumab. AE of special interest, if you look at by the histologies, we also presume that in squamous cell carcinoma, because there is more cavitation, you will have more hemoptysis, but this does not really happen. All the epistaxis, pulmonary hemorrhage, GI hemorrhage, venous thromboembolic events were by and large similar. So, the drug is slightly more effective than docetaxel, but nobody has been able to beat docetaxel. Whether it is Pembro, the KEYPIPE-2 study, whether it is olaparib in addition to pembrolizumab, whether it is sotorasib which has been able to, the more you have these trials, the more you realize that docetaxel is still the king. But this was a trial actually which has helped in slightly increasing the PFS. Now what about the aggressive disease? And this is not your spouse looking at you when you come home at 8 o'clock in the night after attending the YAR. This is an aggressive disease which does not respond to treatment with first 3 cycles of chemotherapy. So 17% of people who had progressive disease as their best response were basically analyzed. That is 1 in 6 patients will have a bad rapidly progressive disease. In this, remember when nivolumab came over there, they found out that people who progress within less than 9 months should not be given immunotherapy, more than 9 months should be given immunotherapy. And this is the trial which showed aggressive disease. You give 9.1 months versus 5.8 months of PFS, of OS, in dosi plus ramucirumab, which was by and large equal to what you get. So 9.1, 5.8 and 10.5, 9.1 was the one. So the docetaxel arm did slightly worse, but the Cyramza plus docetaxel arm did much more better in people who have aggressive disease. So again, there was a 3.3 months advantage, and 57%. I don't want people, and although it's a sponsored symposium, 57% is very high, but that's because the denominator is so small that anything which you give will have an increase. But still, there was a 3.3 months advantage over here. And the overall response rate again here were consistent with the intention to treat population. What about the Indian subgroup? This was the data published by Kumar Prabhash, and what they basically found out was that people in India, in Asian subgroup also, people tolerated the treatment very, very well. Dosi plus ramucirumab is better than docetaxel, which was there with OS, which was there basically with PFS. The advantage was actually was there. So in Kumar Prabhash's conclusion, or the author's conclusion, ramucirumab may be considered an important therapeutic option in second line progressive disease therapy. Now, what about people who have received immunotherapy and chemotherapy, the first one? Is there any data for that? People will say, chalo wo to ho gaya. Now we are all rich people, keynote 189 has become the standard. So if people have gotten immunotherapy plus chemotherapy, can you still go ahead and give them dosi plus ramucirumab? Or who have got the, this is also for people who got Paclitaxel carbo. So it doesn't really make a difference, whether you've got Paclitaxel carbo or Gem carbo or Pem carbo, the drug still has it is the same advantage, doesn't really make a difference. So is there any relevance of data? Is there any relevance of data of the history channel is what I call ramucirumab in 2023. This was a German subgroup analysis which basically got 77 patients from 9 thoracic oncology centers. Please again look at it. 77 patients from 9 thoracic oncology centers, and it's a published point in Translational Lung Cancer Research 2021. I think we should all put in our patients, especially from people who have got larger volumes. Any data is a good data. We should back it up. So So what they basically found out was that after they progressed on the first line chemoimmunotherapy, people got dosi and ramucirumab. And again, the data over here is that there was a number of cycles received was 6, response rates of around 25%, stable disease of around 23%, progressive disease of 23%, PFS of 3.9 and OS of around 7.5 months. Second line is basically all that you get over here is 8 months to 10 months is what you basically get. So with this, to conclude, docetaxel still remains the king. Dosi plus ramucirumab, the Revel trial is the only trial which has shown a slight 1.4 month advantage in over docetaxel. To me, just because it is a second line therapy, it is not important that we don't discuss. If you are chemoimmunophase, you should have a plan B, because every team member is as important as the next. It takes a lot of people to make a winning team. Everybody's contribution is very, very important, and it's the first line, second line, third line which will basically go ahead and increase the survival. With this, I can spare you of the torture now, and looking forward to the next discussion. Thank you.